Good day, everyone. This is Laura Bonilla with JBS International. Thank you for joining us today. The Substance Abuse and Mental Health Services Administration Center for Substance Abuse Treatment's Division of State and Community Assistance is convening a webinar series for providers to give an overview of the Substance Abuse Prevention and Treatment Block Grant, or SABG. This series covers fiscal and programmatic requirements of the block grant. This session is being recorded for future use, so your participation is your consent to be recorded. Due to the high number of participants calling in, all participant lines will be muted for the duration of the session. If you have any comments or questions for the presenters, please submit them to me by selecting Host or State TA in the drop-down menu in your chat window. To open your chat window, please click on the chat icon at the upper right side of your WebEx window. I will read your questions to the presenters during the question and answer period. CSAT Performance Partnership Grant State Project Officers, or SPOs, will be resources and provide clarification during the session and address follow-up questions following the session. If you have questions about block grant practices in your state, please contact your state agency. With that, I'd like to introduce today's presenter, Larry Robertson, Project Director of SAMHSA State TA Project. Larry, I'll hand it over to you.
All right, thanks, Laura. Already done a sound check to make sure folks can hear. Okay, all right, good. All right, so we're gonna, this is a continuation of a series we started. I think this is session number 3. So for some of you, some of the pieces may be a little bit redundant, but there's a rationale for the redundancy. We want to make sure everything stays in proper context. We're doing page now?
Page up and page in.
Okay. All right. So we're going to talk today about a couple of primary things. First, or throughout the session, we're going to talk about the 2 priority populations that are listed in the SABG. And we're going to talk about capacity management systems, which is kind of a term that's kind of used in general, but we'll explain what it actually means. And other activities that are really intended to help these priority populations access treatment more easily. So, again, the session today is about the SABG capacity management requirements, and we'll explain a little bit of what that is as we go through. So, for those of you who've been around for a little while and those of you who might not have, we'll just give a little bit of historical context. This particular set of requirements kind of came about as a result of concerns that popped up in the, really they popped up in the 80s, and Congress took notice of it and actually started to enforce some requirements in the block grant in the early 1990s. And they were particularly concerned, both the House and the Senate were concerned about the spread of infectious disease among pregnant women and people who inject drugs, as well as the partners of these individuals in the communities in which they live. So by 1992, and then promulgated in actually 1993, a new set of block grant requirements came about, and they really placed a lot of emphasis on identifying pregnant women and individuals who inject drugs as the priority populations. They were mostly concerned about these 2 populations that we're going to mention more about later. They also indicated that these populations should be granted admissions priority. We'll talk about what that actually means and how you operationalize it at the program level. And they introduced a set of requirements to limit the wait time and to help increase retention for these of these populations if they end up actually making it onto a waiting list. So the primary focus then was that their concern really was about how do they actually engage these clients quickly. So as you guys all know, motivation can be kind of ephemeral and doesn't last terribly long. So they wanted to make sure that people did not grow tired of waiting for admission, that they didn't lose their motivation or otherwise fall between the cracks. And so collectively they put together this set of capacity management requirements that are outlined in the block grant. And I think if you are in this, if this is your first of this series of sessions, one of the things that we've mentioned in the previous sessions is that if you get block grant funds and you serve these populations, these requirements actually are relevant to you. They are in full effect. So one of the things that, therefore, programs to receive block grant funds for treating individuals, you have to admit priority populations within the time frames that we'll talk about. You have to offer them interim services when they cannot be admitted within those time frames, and you have to have effective systems for tracking, maintaining contact with, and reporting on these populations. So the aim is pretty simple. Aims are pretty simple. One is to facilitate quick access to care. And it's really not about the length of a waiting list that they're concerned about. The concern was really about how quickly can someone access care. It's no different than going to a grocery store and you wait in line, a long line at Costco, but you get through it fairly quickly, but you may go to the supermarket and a similar line will take you a lot longer to get through. It's just a matter of how quickly you can actually make it through and into a program. They were obviously concerned about this slowing the spread of infectious disease. At that time, they were primarily focused on HIV disease and on tuberculosis. Obviously, today, we've also got hepatitis C that is a sleeping giant as well. And they were concerned about the documenting service need. This is a good way to find out kind of unmet need, both in terms of populations that aren't being served well, where you might not have sufficient capacity in certain types of services, levels of care, as well as where you may not have sufficient capacity in specific regions of the state. So those were all things that were of concern, and particularly aims of capacity management, in addition to basically providing quick access to care. So what the block grant requirements call for then is that all states that receive block grant funds, so that essentially includes all 50 states, the 6 Pacific U.S. jurisdictions, the United States Virgin Islands, the Commonwealth of Puerto Rico, the Red Lake Band of Chippewa Indians, and the District of Columbia all have the same set of requirements that call for programs to give pregnant women preference in admission. To also refer pregnant women to the state when such women, when they cannot be admitted, and to publicize the fact that those services are available for pregnant women, and in fact that pregnant women also get admissions preference. And this is kind of a crucial piece that lays out the specific order in which priority populations should be served in a program. So if you have multiple people on a waiting list and any are pregnant and or inject drugs, this is pretty much the kind of the dictating factor here. Pregnant women who also inject drugs should be the population that goes to the top of the list. So even if they've come in and then other people have been there for a while, they go to the top of the list. The only people that they would not surpass on the list are other pregnant women who inject drugs. The next population that kind of floats to the top of the list would be pregnant women who are not injecting drugs. And then the third population would be individuals who inject drugs but are not pregnant, obviously. And then pretty much after that, states and programs can devise their own, come up with their own priority populations. For some states, we've heard a couple of states mention that women who are parenting, or programs will say that, or they might have people who have co-occurring disorders, or people from the criminal justice system. So the block grant doesn't really speak beyond these first three, but what I wanted to emphasize is the fact that this is the precise order in which people have to be placed on the waiting list and kind of ready for admission into care. And it's been a lot of questions about that over the years, and this has been pretty much static for the last 25 years. The other thing that the block grant called for way back in the day was to have programs report to the state when they reach 90% capacity, and that they must submit those reports within 7 days. And so I'm just going to pause there because there are a couple of points on that. Today, if you've got a situation in which you report census data and availability data to the state through some sort of automated process, you probably have met this requirement because you're doing it in real time and you're actually doing it faster than, so therefore you're doing it faster than what the block grant calls for. If you've got no mechanism, it's probably a conversation you want to have with the state about how to make this happen. The other requirement is that people who inject drugs and are coming into block grant funded programs must be admitted within 14 days. And there are some conditions that if a program is unable to meet that 14-day time frame, there's some conditions that, other conditions that they have to meet, which we'll talk about. And the first of which is that they are then given the extension of up to 120 days, but a few things have to happen. They have to be placed on a waiting list, and there has to be some sort of mechanism for maintaining contact with them while they're awaiting admission. And they have to be offered interim services within 48 hours. And we're going to talk about what interim services consist of. Okay. Capacity management systems also require that the states maintain a continuously updated record of these 90% reports, and that they also make excess capacity available to block grant funded programs that serve individuals who inject drugs. And so the whole idea here is that if someone shows up at one program and can't be admitted, there's the possibility that they can be rerouted to another a program that's at least clinically appropriate for their needs. And if you've had queries from the states also have to have some sort of effective means for monitoring programs' compliance with the requirements. And so the little checklist tells you some of the things they might want to look at while they're out. If you've got an automated system, there's a good chance that monitoring can take place through that, because they can tell an automated capacity management system or waitlist system, they can tell how long someone has been waiting. They can tell if they meet a priority population, if they've got a unique client identifier, when they come off the waiting list and the conditions under which they come off the waiting list. So all of those things can be met through an automated system. And if the state doesn't have an automated system, then they can actually come out and do record reviews to determine the extent to which these things happen. So just kind of in a little further context, you can kind of think of all of this as three components of capacity management. One is identifying priority populations, who we've talked about. Another is waitlist management, and the third is interim services. So I'm just going to walk through each of those fairly quickly. So as I mentioned, Congress was concerned about fetal exposure to alcohol and drugs, as well as the spread of infectious disease through injection drug use, but also in utero as well. So they identified the populations that we've talked about and prioritized pregnant women who are seeking treatment, as well as individuals who inject drugs and are seeking treatment as their priority populations. So what that means then is that capacity management systems have to have some effective means for identifying members of these populations and prioritizing them. And I talked a little bit about that priority order earlier, the 1, 2, 3 of individuals who are pregnant and injection drug users, followed by pregnant women, and third, individuals who are injecting drugs. So whatever kind of capacity management system you have to have the ability to do that. If it's paper and pencil, it's a little more challenging because you have to actually manage that by hand. What we've seen of a couple of pretty good systems, automated systems that actually have the ability to prioritize these individuals, is that they actually have algorithms built in. And so depending upon what is identified, what attributes clients have coming in the door, it will essentially bounce them to the top of the list if they're pregnant and also injecting drugs. And then accordingly, if there are multiple individuals who fit that, they will actually then put it in the order in which people appear. And so you still kind of go to the top, but then you kind of fall in another line. That's not a very complicated thing, but it does require a degree of sophistication in an automated system. And then you have to have the ability to track them, and automated systems tend to do that. But you can do that through spreadsheets, paper, and pencil as well. It's just a lot easier to do it in an automated way. So a lot of the second component behind identifying the priority populations is waiting lists. And a lot of the guidance that we've received over the years or that we've used around waiting lists dates back to 1992, but it still holds true for the most part. CSAT's predecessor agency, which was the Office for Treatment Improvement, had a consensus panel come together, and they actually came up with a uniform wait list definition. And so much of what we look at in terms of the elements of a waiting list come from that definition from 1992. There's a little anachronism here, which is instead of defining it as a document, we can just refer to it as a log, and that log could be paper, pencil, it could be web-based, it could be some other kind of electronic form. So just ignore the word document. But basically what we're talking about is some sort of log that retains information on people who are seeking treatment when appropriate treatment slots are not available. And it also maintains some semblance of capacity. So whether you have, if you're a residential program, whether you have a bed available or not, or if you're an outpatient program, whether you have individual and group activities that can actually accommodate additional clients. It also really focuses on individuals who are eligible for the program. So it's not just that they're seeking treatment, but they also have to meet eligibility criteria. So those basic three components, it's, folks are seeking treatment but can't access them when appropriate slots are available, that there is capacity data, and that the individuals who make it onto that list are actually eligible for the program. So this is just a little schematic of some of the stuff that a comprehensive wait list would actually happen to include. And so in the 1992 consensus panel report, these are the things that they identified. And I'll kind of talk a little bit about the rationale for them. So there's application and sequence number. There has to be some kind of way of determining the order in which people made their way onto a wait list. And if all things being equal, meaning you've got your, if you shake out properly the priority populations that I've talked about, then you have to have a way of determining which of those individuals who meet the same, priority population group, which of them came first, second, third, and so forth. And that's where the application and sequence number comes in. There's also the desire for dates and types of contact to be maintained. And states pretty much vary in what they require here, but if you want to meet the requirement, a lot of basic practices can stay in place. Over the years, there were many programs that did not capture consistently data on people who were waiting for treatment, but we're really recommending that it's good practice to actually open up some semblance of a record on individuals who are on a waiting list, even if it's minimal data that you're capturing, but to kind of keep it somewhat disciplined. If they were removed from the wait list, when did that occur and why did it occur? I'll talk about the couple of conditions that can be met, that have to be met to remove someone from a waiting list. And then, not unlike any other kind of form of documentation, some indication of who actually is recording the information that's in the record. And in addition to that, what kind of screening mechanism was used, and where's the program located, basic client contact information, and disposition, ultimately meaning did the individual get admitted, did they refuse treatment, did they disappear, or anything of that kind. And so you want to be able to say that. So how and when the person was informed of the disposition. So if you've got a slot available for them and you're referring them to a treatment program, even if it's within your own agency, how and when did that happen? What the kind of level of care is that you recommended them to, or any other kind of service. So someone may show up on the wait list, and if you determine that you really need to refer them to a medical facility because the medical crisis is such that that's kind of paramount. Anything like that, follow-up contact with the agency. Big concern here is whether or not the connection was actually made, not that you just gave a phone number or an address or a website, but there's actually really more a warm handoff, and that you can actually be assured that the person actually made it from point A to point B. Then priority categories for admission and individual status, and that just goes back to the priority population pieces that we talked about. Again, are they pregnant and or do they inject drugs? For pregnant women, there's also a couple of other requirements. One is that you have to maintain an updated system for identifying treatment capacity for pregnant women and a mechanism for matching them to treatment with sufficient capacity. And that's kind of pretty apparent, but I'll just mention it anyway. The whole notion there is that what you would want is to be able to reroute individuals, pregnant women, if they cannot be admitted into the program that was their first choice. Obviously, a lot of this is going to be based on both clinical and medical necessity and eligibility, and so you would want to reroute folks to programs that are appropriate for them in terms of what their profile presents. For programs that serve individuals who inject drugs, I do actually want to mention a couple things that when a lot of us first started doing work around when these block grant requirements came out, there were a lot of ways that states interpreted what we meant by programs that serve individuals who inject drugs. And I think today we've basically kind of gotten to the point that we're not just talking about methadone programs or therapeutic communities. We're pretty much talking about all programs that serve individuals who have substance use disorders, because what we're finding is that it's a rare instance for a program to not have individuals or some individuals who inject drugs. And so we're looking at this is kind of a ubiquitous requirement for block grant funded activities or treatment programs. So in addition to what's already been mentioned, we're looking to have programs have unique client identifiers, even once they are actually on the waiting list. One of the obviously rationales for those of you who kind of work with other providers, or if you have programs, multiple programs in the state, it's not that uncommon for people to kind of show up on multiple waiting lists trying to get into care. And so it may artificially clog up the wait list. So you want to make sure that you have a clean count across the state, but also that you can track episodes of care as people come in, if they come in over multiple visits. That client identifier is a way to kind of track things more easily. The other requirement, just like with women's services, is that programs that serve people who inject drugs should also consult with the state's capacity management system to see if there's an opportunity to transfer individuals on the wait list. And just a few kind of emphasized terms in the statement here, that they need to be within a reasonable geographic area. So if the person is eligible or meets the criteria for outpatient services, you're certainly not going to refer them to a program, 100 miles away. It's possible if the state has this as an option to do that perhaps for residential services, though. And that is a possibility. And then the other piece is at the earliest possible time. If other programs are also pretty much booked in terms of their capacity, the earliest possible time is kind of a relative statement, but the idea is still the same, to try to get people in care as quickly as possible. Two conditions under which people can be removed from a wait list, pretty straightforward. You can't locate them, or they refuse treatment. If you can't locate them, you can't treat them. If they refuse treatment, you can't make them, come in. So those are the two basic conditions under which someone can be removed from a wait list. And you probably, to keep it moving, you certainly would want to have some conditions under which you can do that. So the third component of capacity management is interim services, which I haven't talked a lot about, but the whole idea, if you go back to some of the aims of what Congress was concerned with and why the block grant requirements have this piece in here, is that they want to be able to have the opportunity to not only stay in contact with folks, but to keep them motivated and to keep them involved and to stay connected so that they don't lose track of them. It's not unusual, as you all know, for folks to lose their motivation in between visits. And so what interim services helps to do is to provide some temporary service until the full bore of a treatment activity can be provided to people. So what the block grant basically says is that interim services have to be offered within 48 hours when pregnant women or individuals who inject drugs can't be admitted because of insufficient capacity. The tipping point is a little different for each, and so there's some kind of caveats that go along with that in terms of that 48-hour period. So interim services, as I mentioned, are provided to help folks, to help maintain motivation and to keep people engaged and to retain them while they're until they're admitted. These are what the interim services entail. One is counseling and education about HIV and TB. Another is counseling and education about the risks of needle sharing and risks of disease transmission to sex partners and infants. Counseling and education about steps to prevent HIV transmission and referrals for HIV and TB services if necessary. And obviously you can detect a strong public health orientation and go back to the aims of the concerns of Congress. They were very much concerned about the spread of infectious disease and through these various means. But they're also concerned about what happens with pregnant women and the fetus, and so they wanted to make sure that moms were referred to for prenatal care and that they were referred for counseling on the effects of alcohol and drug use on the fetus. So those are the basics of what constitute interim services. The additional piece, and I don't remember the answer to a question that someone asked in another session, but I'm just going to answer the question, address this up here. But interim services could also include federally authorized methadone services that supplement but do not supplant comprehensive methadone services. And so just a minute on what the difference between supplement and supplant are. It's no different than any other federal funding that you get. There's typically a condition that upon receipt of federal funds, you cannot supplant those federal funds, meaning that supplement means that you can either take the funds to add to or enhance services. Supplement means that you're now taking these funds and you're replacing existing services with this new funding. And that's pretty much prohibited under the block grant under any circumstances. But the good news is that you can actually take the funds and actually use it for this form of medication-assisted treatment. And the question that, and Becky, you might remember, that I can't remember that popped up on one was whether or not any other form of medication-assisted treatment, I don't know if Courtney or Kathleen remember this, if any other form of medication-assisted treatment can be funded or used for interim as a part of interim services? You don't remember?
Not off the top of my head.
Yeah. So that was a tricky question. That was the first time actually I'd ever heard that question. So I don't remember the answer. So Courtney or Kathleen, if either of you remember or know, you're certainly welcome to kind of chime in. So the other thing that we have encountered with interim services are a few challenges, or at least some things that the block grant doesn't speak to so explicitly. And so what we want to just kind of do is just bring them to your attention. One is around defining interim services. Beyond those specific services that I mentioned, those are the required things, but there are other things that people can do. But this is really a state thing, that the state can actually identify interim services that go above and beyond what we've outlined. The state can also figure out how it wants to capture and report interim service, or how they want providers to capture and report interim service data. For a good bit of time, we didn't have these data being reported, but more recently we've run across some states that actually have decided they do want to give and get credit for providing the service. And so one of the ways of doing that is basically by having service data and client data for individuals who are on the wait list and who are also getting interim services. Some states are also ensuring that this is not an unfunded mandate, so they ensure that they pay or reimburse for the provision of interim services. And so it's typically kind of a hand-in-hand proposition that if you're capturing data, then you also have service definitions and some sort of reimbursement rate for interim services. I actually didn't mention, I mentioned it, but I didn't talk about it. So the condition, just want to stay on interim services for a second. The condition for the 48 hours is a little different. If you remember when I talked about injection drug use, and I said that you have to admit someone within 14 days, and if you can't do that, then you have to offer them interim services within 48 hours. For pregnant women, it's just a straight 48 hours. If you can't get them in within 48 hours, you automatically within 48 hours have to start offering interim services. So that time frame is a little tight. But again, still 48 hours is a kind of a common theme. It's just that what triggers the 48 hours is a little different condition between those two populations. All right, so kind of one of the things that has happened more, again, if you think about 1992 and where we were in terms of technology, people were submitting data to the states on floppy disks, faxing, not even emailing so much, because not everyone had email back at that time. And so it was not necessarily the set of conditions that we have today in terms of a lot of web-based and open source kind of applications. So we've seen an increase in the number of automated systems, and obviously there are a whole host of advantages and some concerns around automated systems, with more advantages than anything else. So a lot of states have actually implemented some form of an automated system, and it's made life a little easier for them on a number of fronts. And these are some of the benefits that they've been able to derive. One is that their data are nearly real time. They don't have to wait for 7 days for a report. They know that a program has a certain census and therefore capacity to serve more or not. So they've got pretty comprehensive capacity and waitlist data. They also can take a look. States that have these systems have a comprehensive picture of the state, and so they can make those adjustments in terms of moving people around from one organization that's kind of full to another. So there are, obviously a whole host of advantages. And they can also analyze and report on waitlist data and benefit from that as well. I got ahead of myself. So they can route priority populations to appropriate levels of care. That's one of the things I mentioned. Really important, they can start to engage in more quality improvement activities and look at quality measures like access a little better. And one of the big things is how long does it take for someone from point A to point B to get into care. And so dropping down to the last bullet, they can also establish objective performance measures related to access. They can forecast caseloads and figure out level of need within and across programs much more accurately, because you now have a better ability to see what's coming down the pipe, what's your client population looking in the pipeline looking like. And they can, in the big picture, they can start to determine the gap between demand and capacity. And again, when I talk about that, we really talk about, who are the populations that are coming in? Do we have the levels of care to serve those client populations? And are they situated in the appropriate places geographically throughout the state? So those are huge advantages for the state. For providers, there's also just the basic advantage of knowing what your demand is and who's coming in, and whether or not you need to seek assistance from the state to possibly identify other programs where folks might be able to be referred. The condition, though, is it's pretty much the same as anything else. You can only extract good information out of a system if you enter accurate, complete, and timely data. And so at the provider level, kind of the aim would be to make sure that you kind of maintain this information on a daily basis, and that those who are managing the system, whether it's at the provider level or the state level, really need to use the data to direct and report on waitlist clients and capacity management systems. Otherwise, the people, if any of you have ever been engaged in an activity where a system has been put into place but it's not really used, it kind of loses some of its legitimacy. So if you really want it to be viewed as legitimate and used effectively, then people need to see the results of it. And that's one of the ways to boost its credibility. I don't think they can hear the baby shower party that's going on next door.
I don't think so.
I can, though.
They're not that rowdy.
Yeah, they're good. They're not yet. Maybe after the second apple juice. One of the kind of an overarching challenge that, or a set of overarching challenges that have popped up with capacity management, I think it was back in 2008, CSAT had us convene a small consensus panel of folks from various states throughout the country and two, I think, regional entities within a couple of states. And we wanted to take a look at a number of things, and a lot of what we found was that many of the requirements of the block grant pretty much stood up okay, but there were some gray areas that required some conversation. And these are a couple of the items. Actually, these are the most significant items that we found. And one had to do with defining capacity. And we didn't come up with a definitive answer, but we basically recommended that states try to have some sense of understand that this is actually an issue and that they need to have some internal to the state, some consistency. And so obviously defining the capacity of a residential program is a non-issue. How many beds you have determines your capacity. Even in day treatment programs, it typically means that the number of slots is fairly well determined, but outpatient is another story because of its service mix. You have the combination of individual, group, and other kinds of services, and so the question is, how do you actually assign capacity based on that mix? However it's done, what we just simply recommended is that the states come up with some sort of consistent way of operationalizing capacity for outpatient services. So that's one of the most significant things. And we spent a good bit of time, and it kind of came down to we weren't going to, kind of come up with a very prescribed answer, but come up with a set of questions that folks might want to consider. Actually, question. I don't know if we did it yet or if we're going to send them. There's the report from that consensus panel, the ones that usually send out.
We can send it to them with the link and the recording. And
so we're going to send you actually the report from that particular meeting and that thing. Do we also, Becky, you also send the wait list definition? Okay. So we're going to send you a couple of the documents that will, so the 2008 consensus panel and the ninth one, just on capacity management, and the 1992 consensus panel on the uniform wait list definition. The other thing that we spent a good bit of time talking about was measuring access. Basically, when does the clock start to tick? And so we talked about, well, does it start to tick when someone first makes a phone call, when someone comes in for an assessment, or does it tick at the point at which you've determined the level of need and therefore level of care? And so again, we had some thoughts about it in the report, which you can read, but the biggest thing was that the states probably need to be fairly consistent about how they recommend what actually constitutes the clock ticking. And when I say the clock ticking, if you go back to someone needs to be admitted within 14 days if they're an injection drug user, or be given 48 hours to start interim services, or if they're pregnant, they have 48 hours. So when does that clock start to tick that says, okay, now the 48-hour clock is on? And so the report talks a little bit about some of our thoughts around that. What we concluded in that particular report was really what seems to be certainly the case today in terms of what makes a difference, whether it's a web-based or paper and pencil capacity management system, is that however you do it, there were three things that we thought that seemed to make a difference across the country. One is that the expectations are clear. What's capacity? When does the clock start to tick? The other one is that as close as you can get to real-time data, the more valuable this is. If we go back to the spirit of what Congress was concerned about, which is how quickly can people be admitted into services, particularly these two populations, to the extent that you can have real-time capacity information, the better you can serve that population, those populations, by getting them into treatment today rather than 7 days from now. The third thing is that unless someone is assigned who is specifically responsible for managing and monitoring these activities, it tends to be kind of a side activity. So what we found is that those states and programs that actually saw this as someone's, not their whole responsibility, but it was something that was a part of their normal routine, that it was more disciplined and it was better managed and things moved. So that was the third piece that we recommended. That's it. So we can take questions. We have about 15 minutes. Do you have any?
Okay, so we have one question so far. If the use by injection is historical and not part of the presenting issue, does that person still meet priority population for admission?
Yeah, that's actually a good question. I think that's another one that we need to answer. I don't know if Courtney or Kathleen can take a run at that one. I mean, most of what we've been looking at is that it's been recent, but I think that actually is a pretty good question.
Okay.
So do we have Courtney or Kathleen on?
They're on. They're unmuted, so feel free to chime in if you have any answers.
Okay. So how about if we kick that in writing to, we'll kick it in writing to SAMHSA and see if we can get some guidance.
Okay. So the next question is, what role does SAMHSA play in the SA block grant?
That's the whole question?
Yep.
Oh, okay. SAMHSA administers both the Substance Abuse Prevention and Treatment Block Grant through CSAT, the Center for Substance Abuse Treatment, and the Center for Substance Abuse Prevention, because that's what it covers. And it administers the Community Mental Health Services Block Grant through the Center for Mental Health Services. So basically, SAMHSA is the administrator of both block grants. And a lot of the support that SAMHSA provides to states and communities is actually through the block grant, including contracts like ours that actually provide technical assistance.
Okay. The other question is, can you go back to slide 29 about the requirements for interim services? They missed a few points on the first two slides.
Okay. Let's see. What slide is the last one? Okay.
And we have a comment from Courtney regarding the first question.
Okay. You want to hold on that, and then I'll do. All right. So, so here are the basic pieces of interim services. One is the trigger around the 48 hours, and what I failed to mention when I mentioned that earlier, but I did follow up on it, is just to clarify the 48 hours. For people who inject drugs, the 48 hours kicks in if it's determined that they can't be admitted within 14 days. For pregnant women, the 48 hours kicks in immediately, that it's determined that they can't be admitted at all, immediately, rather. So the requirements for interim services are these, and I'll go through them once more. Counseling, and a lot of it's really about HIV and TB. Counseling and education about HIV and TB. Counseling and education about the risks of needle sharing and risks of disease transmission to sex partners and infants. Counseling and education about steps to prevent HIV transmission. Referrals for HIV and TB services if necessary. And then with respect to pregnant women, referrals for prenatal care, and referrals for counseling on the effects of alcohol and drug use on the fetus. And there's also the provision that you can provide federally authorized methadone services that supplement existing services. Okay, so Courtney's answer.
Okay, so if a person indicates they have previously used IV drugs, they are considered part of the priority population, regardless of what they are presenting for.
So it's historical as well as current. Okay.
Okay. And the next question, is the priority admission in regard to the receiving treatment facility or the county receiving the treatment request?
It's essentially the program. I worked in accounting years ago. The county has its own requirements. So in our case, what was incumbent upon our county was that we had to make sure all of our programs adhered to the requirement, but each individual program had to adhere to the requirement.
And Courtney's having some issues with sound, so she's just sending the comments.
Okay, that's fine.
So also, you mentioned something about MAT earlier. Mm-hmm. So her response is, SABG funds, other than primary prevention set-aside funds, may be utilized to purchase naloxone or Narcan and the necessary materials to assemble overdose kits and to cover the costs associated with the dissemination of such kits. SABG funds may also be used to provide MAT services not covered by other means. And that's all I have from her. Okay, and then we have another question. It is my understanding that interim services can be provided by referral. Is this correct? So if an agency isn't able to provide the interim services, they may refer the client to a health clinic or other provider.
Yeah, most of the services that are on this list, I keep it interrupting. a lot of these services you can either provide directly or make arrangements. The big thing that the program has to do, though, is maintain the wait list, maintain contact, and coordinate this care. So it's still the program's client, and they're referring out to these services.
Okay.
So, but a lot of, I mean, you're health educated, you know, where do you get most of this stuff? The health department.
Okay. All right. So next one is, sorry to go back to this, but does SAMHSA define recent or historical use for admission, or can states define historical use such as use within 30 days prior to admission? Asking, are there clear definitions to recent and historical use?
All right. So Courtney, you want to try that one too?
We'll give her a couple minutes to type her answer.
Do you have any other questions?
Okay, so Courtney said, SAMHSA does not define recent versus historical. And so far, that's all the questions we've received.
Okay. There's nothing else.
Well, just to let everyone know, I will be sharing the PowerPoint slides with the resources and the recording tomorrow. So look out for an email from me.
And next week's session, same time, Thursday the 14th, is going to be on the financial requirements of the block grant, and particularly those that are relevant to provider, county, intermediary, anyone below the state who receives money from the state, what the requirements actually entail for treatment services.
All right.
Okay. All right. Thank you.
Okay. Thank you so much.